Good morning, everybody. At the outset, let me thank Dr. J. Krishnan for having given me this opportunity. And I know I'm the barrier between you and lunch, and I'll try to be quick because of that. So, recurrent pregnancy loss, something which is day to day, coming back from all hi-fi things, let's come back to reality. Something that you and me encounter every day, and still, most of the time, we don't know what to do. So, just some of the, Dr. J. Krishnan told me to talk about the recent concepts, but when you look at it, there are very few recent things because evidence is extremely limited on recurrent pregnancy loss. Now, the recent committee opinion, ASRM and ESHRE say that you can define recurrent pregnancy loss when you have 2 or more consecutive spontaneous pregnancy losses under 20 weeks of gestation. And it can be primary, even though the conventional definition was 3. Now, most of us have started investigating with 2 losses, and that is what ASRM says. And there are a whole lot of causes. I won't go into the causes in detail, but just remember, can you always find a definite cause? That is the most important problem, because only in 50% we get a definite cause, and only once you have a cause you can treat, but otherwise what do? And then remember that in each pregnancy you can find that more than one contributory factor may be there. Each may have a different cause. And there are confounding factors like age, increasing age, and the previous number of miscarriages. As they increase, you find pregnancy loss goes on increasing. Now, when would we start investigation? Traditionally, we were taught after 3, but now, as I said, most of us would start after 2, especially in older women, and of course, following ART. Or the literature says that even after a single second trimester loss, you are probably justified in doing investigations for thrombophilias. Coming to genetic factors, we all know that parental abnormalities are probably implicated in 3 to 5% of couples with recurrent loss. The most common are balanced translocation in the couple, which translates to unbalanced translocation in this thing. But remember, even though there is a 25% chance of pregnancy loss, it is very important to counsel them that most of them eventually do produce normal offspring. So I think especially when you have genetic problems, it's important to tell them that eventually most of them would have a normal child. And as the number of miscarriages increases, you find that the prevalence of chromosomal causes decreases and the chance of maternal factors is more. Again, if you find that in a particular pregnancy the karyotype is abnormal, you can most of the time counsel them that there is a much better prognosis in the next pregnancy, because the probability is that she is unlikely to have an abnormal karyotype in the next pregnancy. Now, whether to do products of conception or parenteral has been controversial. Both RCOG and ESHRE recommend that you go for products of conception karyotyping, and only if they are abnormal, or when you cannot do POC testing, go for parental karyotype. But especially in our setup, you find a lot of pitfalls for products of conception karyotyping. In 50% of cases, you find it's unsuccessful, usually due to maternal overgrowth of fetal cells, and poor, especially when a long time has evolved between the time of culture, from demise till culture. And you find that, especially in our setting, probably parental karyotyping would be more cost effective. And remember, it's not always translocation. Single gene disorders are also responsible for quite a lot of these losses, which for most of them, prenatal diagnosis is possible today. And PGD is definitely, it's probably not the answer, but it's probably one answer, the ultimate answer. And you find that the miscarriage rate is, you find that the miscarriage rate is more. You find that the miscarriage rate is about 87%. It comes down to 17% after PGD. But would you recommend PGD for all parents with a abnormal karyotype? I don't think so, because parents should be told of the low birth rates following IVF compared to natural conception, and also that they have a 50 to 60% chance of a healthy live birth following natural conception. And finally, the ultimate, of course, donor sperm and donor egg, especially if they cannot afford all these things. Advanced maternal age, the impact on risk for pregnancy loss cannot be overemphasized. You have increased risk of maternally derived trisomies. Probably natural selection of better quality oocytes occurs earlier in reproductive life, and so advanced maternal age is definitely a risk factor. And we all know that as the rates of fertility declines, you find that the rate of spontaneous abortions increase. Now, coming to anatomical factors, there are a whole lot of anatomical factors. All the anomalies, the uterine anomalies, Hopefully, we are not going to see T-shaped uterus, because I think the entire generation of diethylstilbestrol mothers have finished their reproductive career. But submucous fibroids, large polyps, intrauterine adhesions. And the statistics show that 1 in 6 to 10 women with recurrent miscarriages, you do get a structural uterine defect. So that it's vital to look for uterine problems. And the culprit is small uterine cavities, suitable implantation sites are less, aberrations of vascularization, and very important, don't forget the old dictum, associated cervical incompetence. Nowadays, the teaching, we do not recommend routine cervical incompetence, but probably these are candidates for repeated ultrasound screening and deciding to do an incompetence if you if you find that the cervix becomes shorter. And you find that both early and late, and most of the second trimester, most of them, uterine problems lead to second trimester miscarriage and a live fetus at expulsion. But you do find early pregnancy losses, especially in septate uterus. Septate uterus, yes, definitely the most common anomaly. 25% of early abortions and 6% of late abortions and premature labors. And definitely the dictum is a septate uterus, where in recurrent pregnancy loss, I think since a long time we were treating, and even in infertility, if you see a recurrent septate uterus, you would definitely do a see and treat approach. Hysteroscopic septal resection would definitely be done. In a uniconvate uterus, which would account for 20% of anomalies, you find hypoplasia of one Mullerian duct. It may be accompanied by a rudimentary horn, and that would decide on surgical management or not, depending on whether it's communicating, non-communicating, etc. But the literature search at the moment does not advocate doing any surgery per se for uniconvate uterus. Doing a lateral metroplasty is not yet accepted, and cervical encerclage, they say, definitely may improve pregnancy outcome in uniconvate uterus. Diadelphys is the least common anomaly, and we know the abortion rates are 43% and preterm birth rates are 38%. If there is a vaginal septum, definitely you would resect the septum, but no other surgery, because ultimately most of these pregnancies do reach at least 20, 30 weeks, 32 weeks. Again, a biconvate uterus, you get abortions and preterm labor. A Strassman metroplasty used to be done previously, but never as first line. And as I said earlier, most of the biconvate uterus, ultimately you do achieve a live birth, but probably in selected cases, repeated losses, you might consider a metroplasty. Asherman syndrome, poor implantation, decreased blood supply and infection, very bad pregnancy rates. Even after your excision of adhesions, you find that the pregnancy rates, the continuing pregnancy rates are extremely low. Endometrial polyps, questionable, should we treat or not? A questionable value in RPL, definitely before IVF, but regarding recurrent pregnancy loss, the evidence is limited. But obviously, if you see a polyp, you would treat it. Do fibroids cause recurrent pregnancy loss? Eshrey says that only submucous fibroids are definitely associated with RPL and should be removed. Intramural fibroids, which distort the cavity, also could probably be removed. That's what they say. But regarding other intramural and subserous fibroids, the association is still not clear. And I would say that myomectomy would be best considered on an individual basis. For example, if you have a very large subserous fibroid, probably you might be justified in doing it because it can lead to problems in pregnancy. Transvaginal scan is definitely mandatory to assess the cavity, and you could add sonohysterography to pick up anomalies that would increase your rates of detection. And of course, MRI and 3D scan, definitely if you have an MRI, probably that would be good, because it would obviate the need for just doing a diagnostic. You could be more prepared when you go in with your scope. Coming to cervical insufficiency, this is something you had a whole talk on it yesterday, and so I'm not going into the details. Cerclage, I think cervical weakness is grossly overdiagnosed, and you should limit cervical encerclage to only those women who are likely to benefit, because otherwise you run the risk of stimulating uterine contractions and induce and being an iatrogenic cause itself. These were all touched upon by Dr. Mridubhashini yesterday. A history-indicated cerclage, yes, definitely with 2 or 3 losses, you would go for a history-indicated cerclage, but with a single loss, probably an ultrasound-indicated cerclage. Following up these patients, and when you find that the cervical length is reached 25 millimeters, probably you are justified. But otherwise, I don't think, because I think most of us would have had patients we have done cerclage, we've lost the pregnancies, and then they come back to us at, after 28 weeks, 30 weeks without doing anything, and then you find that the pregnancy has continued. Can you do a cerclage prophylactically in the first trimester? No, the recommendation is that you do not do it in the first trimester. You do it only at 13 to 14 weeks after ruling out anomalies. And if you have a suspicious history, do serial scans. What about when you have your routine transvaginal scan shows a short cervix in the first trimester? Again, they say if you have just a short cervix, you repeat it, go on following it, and wait at least until 12 weeks is over. Endocrine factors, routine screening for thyroid and diabetes is not advocated. But, routine screening is not advocated because we know that well-controlled diabetes mellitus and treated thyroid dysfunction are not implicated in recurrent pregnancy loss. But both of these tests, thyroid function tests and hemoglobin A1C, are very inexpensive and accurate tests. And if performed preconceptionally, they would have a better maternal and fetal prognosis for that pregnancy, even though they may not actually be implicated in the loss. And so definitely we would screen for these endocrine problems. Luteal phase defect is not a definite cause except in ART cycles. The diagnostic criteria are not yet defined. And remember that LPD in one cycle need not necessarily translate to LPD in the other cycle. And so we still don't know where we stand with LPD in non-ART cycles. Progesterone for recurrent pregnancy loss. I think all of us do give progesterone. For most of us would give progesterone for recurrent pregnancy loss. A recent systematic review found no evidence to support the routine use of progesterone in the first trimester to prevent miscarriage. However, they did a subgroup analysis of 3 trials and they found that progesterone showed a statistically significant decrease in miscarriage compared with placebo or no treatment. And then the comment was that all the trials included in this systematic review were more than 40 years old and hence there's definitely scope for a large RCT in recurrent pregnancy loss. Regarding polycystic ovarian syndrome, does have an association, as we all know. LH, the elevated free androgen index, are all good predictors. Polycystic ovarian morphology alone will not predict an increased risk of pregnancy loss. And what do we do for this? We still don't know. Insufficient evidence about metformin, as we all saw in yesterday and today's presentations. Coming to infections, torch screening, Cochrane has categorically proven that it's time to be due to torch. And torch screening is only indicated, I would say, if you have a clinical suspicion in that particular pregnancy, or another thing is if it is a treated pregnancy, a pregnancy which has been treated for APLA syndrome and you still lose it, probably you are justified in doing a torch screening or a karyotype to make sure that this loss is not due to APLA itself. Other probable postulations are bacterial infections like bacterial vaginosis, viral infections have been postulated. The evidence for screening for bacterial vaginosis, they say, in a woman with a previous history of in a population with a previous history of, recurrent pregnancy loss, screening for bacterial vaginosis and treatment may reduce the risk of recurrent late loss and preterm birth. So you're probably, even if you don't screen, you might be justified if you treat for bacterial vaginosis in the early second trimester. Chlamydial screening is also indicated in the West. It is not indicated in the general population, but in recurrent pregnancy loss. Just giving broad spectrum intravenous antibiotics, beneficial effects are questionable. Many people do that, but there is no evidence to support it. Male factor, consequences of fertilization, sperm with nuclear DNA damage and microdeletions. You do find a lot of evidence coming with recurrent abortions. But what do we do about this? Questionable. Coming to immune factors, APLA syndrome, I think everyone knows about APLA syndrome, so I'm not going into the details. We all know the clinical criteria to diagnose APLA syndrome, and the pregnancy loss can be occult. You can also have anembryonic pregnancies, implantation failures, etc. This is coming in. It's not just pregnancy losses after the fetal heart appears. And you can get early pregnancy loss before 12 weeks and late pregnancy loss, but now you find that a very high chance of anembryonic breast pregnancies. And the revised Sapporo criteria say that you should have 2 positive tests at least 12 weeks apart for either lupus anticoagulant or anticardiolipin antibodies or beta-2 glycoprotein. And how do you test for lupus anticoagulant? What they say is that any phospholipid-dependent clotting test can be used. The best one, they say, is dilute Russell-Viper Winem test, and you do that along with a platelet neutralization test. So platelets should not neutralize the negative findings in APLA, and that would be the gold standard to look for lupus anticoagulant. Most of us would do the kaolin clotting test or the APTT if you do not have facilities for doing the dilute Russell-Viper Winem. Management, we all know a combination of low-dose aspirin and heparin. Just remember that heparin in prophylactic doses does not require monitoring with coagulation parameters, But remember that you have to look at platelet counts even when you give low molecular weight heparin in prophylactic doses. Which heparin would you use? Both can be used, unfractionated and enoxaparin. However, a recent meta-analysis showed that low molecular weight heparin does not significantly improve birth rates, and they said that the benefit is only with unfractionated heparin. This is a very controversial paper, and I think we have to have a lot more evidence till we can say. So I think most of us would still continue to use both. Some things that you have to remember when you treat pregnancies with positive for APLA syndrome with aspirin and heparin, don't assume that you are going to get, you have to counsel the patients that pregnancy, you're not going to get 100% success in that pregnancy, because they remain at high risk of complications during all the 3 trimesters, especially most of the time you just ameliorate preeclampsia and IUGR. You cannot do away with preeclampsia and IUGR. So you only have an 80% success even in proven APLA patients. Remember to prevent maternal vascular thrombosis in pregnancy and the postpartum period, and especially if there is a previous history of thrombosis, prophylactic anticoagulation is not sufficient. You have to go for full anticoagulation. Coming to immune therapy, because there are a whole lot of immune causes described, the T cells, the natural killer cells, cytokines, etc. They are still all the ACRM committee opinions, everyone says that immunotherapy, including paternal cell immunization and third-party donor leukocytes, do not improve live birth rates, and at the moment they are not recommended. Coming to intravenous immunoglobulin, ASRM committee opinion says that intravenous immunoglobulin should be considered experimental in selected cases with informed consent, and again in the context of a study. They further elucidate that you can try it in the context of a trial in secondary recurrent miscarriage or repeated second trimester losses. It may be useful in women with more than 4 losses and older women without any other cause, but that is not a committee opinion. It is just a comment by one of the authors. Rarity of side effects with intravenous immunoglobulin, but the main problem is, of course, the cost. Now, coming to inherited thrombophilia, most of the guidelines today recommend screening for second trimester miscarriage. The RCOG says that women with second trimester miscarriage should be screened for inherited thrombophilia. If you can't screen for all the five categories of inherited thrombophilia, at least factor V laden, prothrombin gene mutation, and proteinase deficiency. But these are Caucasian data. Unfortunately, we do not have data for inherited thrombophilia in our population, and this is for their data, where they say that you should screen for at least these three conditions in second trimester miscarriage. Heparin, they say, may prevent second trimester miscarriage. There is insufficient evidence regarding first trimester miscarriages and congenital thrombophilia. Hyperhomocystinemia, if you have just elevated homocystinemia without a history of thrombosis, no heparin, just supplementation with vitamin B6, B12 and folic acid. But however, if you have a history of thrombosis, or you find that there is a homozygous MTHFR mutation, or you find that the pregnancy outcomes are unresponsive to your vitamin supplementation, you could consider heparin anticoagulation. Environmental factors, confirmed association with ionizing radiation, organic solvents, alcohol, and all these chemicals. Suspected association with caffeine, more than 300 milligram per day, hypothermia, smoking, etc. Bed rest. Does bed rest prevent miscarriage? There's no evidence in favor. In fact, the opposite is true. It may be harmful. So the RCOG finally recommends only the following definite workup for recurrent pregnancy loss: a detailed pelvic ultrasound, if necessary, with MRI, 3D and MRI, peripheral blood karyotyping in both partners, screening for APLA on 2 occasions, and in selected cases, screen for inherited thrombophilia. So what do you do when there is no definite cause, as we usually see in 50%? If all the above causes are excluded, you come to the diagnosis of recurrent miscarriage of unknown origin, and they say that the use of empirical treatment in these women with unexplained recurrent miscarriage is unnecessary and should be resisted. The recommendations are for both partners to be as healthy as possible before she conceives, and to get any medical condition under control, educate about smoking, alcohol, and drug abuse. And the only intervention that they've found to have demonstrated benefit is serial ultrasound scans in the early months of pregnancy. Probably that is a psychological factor. And I think most of us would agree with this, because you find that you have treated, so you have done all that there is, and you have given, even empirical heparin has been given by many of us, and then you leave the patient alone. The patient gives up everything, and then she comes back with a 6th or 7th pregnancy at, in the late 2nd trimester, and she continues the pregnancy without any treatment. So even after 3 losses, the rates for a successful pregnancy you find are 60 to 65% without any treatment. So women with unexplained recurrent miscarriage have an excellent prognosis for future pregnancy outcome, even without pharmacological intervention, if they are offered supportive care in the setting of a dedicated early pregnancy assessment. Thank you. Just remember that a woman with a single sporadic miscarriage is an 80% chance, and a woman with 3 consecutive miscarriages has a 60% chance of her next pregnancy being successful. Thank you very much.